All right, thank you for joining us on today's event on Demystifying LCDs, the top 10 things MACs want providers to know. This is the second event of our Medicare Education Expo for today. So my name is Mary Sue Gardner. I'm a registered nurse on the Provider Outreach and Education team, and I'm going to be your facilitator for today's event. I've been working in Medicare now for 23 years, and my focus is to provide clinical education in both J5 and J8, Part A as well as Part B. And I'm joined today by Dr. Joelle Vlahakis, one of our medical directors, whom I'm going to be turning things over to shortly. Now, there's a few housekeeping items before we get started. On our website, we have a training center page that's all things education. There you're going to find upcoming events, training materials, encore presentations, and even a whole lot more. So the recording for today's event will be posted to the encore section of our website within the next several weeks, but it's also going to be available on our YouTube page, and that'll happen within the next several days. We received many pre-submitted questions, and Dr. Vlahakis is going to cover as many of those as possible in her presentation today, and those that are really pertinent to the topics that she's going to be talking about today. So if a pre-submitted question is being, covered in another one of today's events, then, or if it was something that's more pertinent to one of today's other events, then we sent that over to that facilitator. And then additionally, there was other pre-submitted questions on policy that were more general, and those were sent over to our facilitator for the open Q&A session, which is the last event for the day. So if you haven't had a chance to register for that last event, the open Q&A session, that is still open. If you have questions specific to this event, we do have a chat feature. You can place your questions into the chat. However, we do want to be respectful of everyone's time since many of you are registered for multiple events. So don't worry if we don't get to your question. We will be gathering all those questions after today's events and let our participants know what the answers to those are. Finally, if you have any feedback about your experience today, there is opportunity to take our survey on this event. Your feedback is very important to us. But if you find you have to leave early, I did go ahead and place that feedback link into the chat feature right now. All right, a disclaimer on your screen is our disclaimer for today's event, and we have to show this at all events. And this just basically says, the information we're giving you today is a tool to assist you, our provider community. But know that Medicare laws, rules, and regulations often change. And it's your responsibility as a provider to make sure you're following the most current laws, rules, and regulations that are in place on the day of service that you are providing those services to your Medicare beneficiaries. So CMS has final coverage determination at all times. So if anything we say today happens to change tomorrow, it's your responsibility as a provider to make sure you're following the rules that are in place tomorrow. On your screen is just acronyms. Medicare's full of acronyms, but these are some of the common ones that we may or may not say in today's event. So if one of us happens to use an acronym and you don't know what it means, you can go ahead and refer to this, or even put it in the chat and one of my colleagues will assist you with the meaning of that. And then finally, our objective for today is to enhance your understanding of the Medicare coverage process. Now, we're going to accomplish this today by discussing how MACs develop LCDs. We're going to explore the role of multi-MAC LCDs, and you're going to gain clarity on contractor advisory committees and open meetings and what those are and what those mean to you as a provider. So I am now going to turn things over to my friend and colleague, Dr. Joelle Vlahakis, who's going to go ahead and start with the formal presentation for today. Dr. Vlahakis, go ahead.
Thanks, Mary Sue. So I thought I'd tell you a little bit, previous slide, a little bit about why I'm bothering with this and why it's become my passion. So I'm a true believer. I was in primary care for a long time, practiced in rural health, did some hospital medicine, eventually found myself as a hospice medical director, did a lot of work in hospitals as a palliative medicine consultant, even taught towards the end of my last part of my career. But I didn't really know what I didn't know about Medicare. I thought I had been swimming in those waters for a good long time. I had perspective from a lot of different places: primary care, rural health, hospital medicine, hospice. We lived by those local coverage determinations. I really thought I understood them. And then I joined WPS for a special project in 2022. They convinced me after the project was done to stay on as a contractor medical director, and I had the temerity to think, okay, let me try that. Well, I'm rather new at this, and I think that I might be in the best position to come to you, still feeling very much like a provider, but pulling back the curtain on some of the things that I've learned in the Medicare landscape since I joined. Next slide, please, Mary. So the first thing that I want to confess is the biggest secret. And that is, although we talk, of course, in terms of local coverage determination and national coverage determination, the vast majority of claims are processed and paid without an associated LCD. Let me repeat that. Most claims are processed and paid without an associated local coverage determination. Think about the way you move about, say, in your clinical practices. Many of the things you submit claims for are just common accepted medical practice. A mentor of mine told me I would be absolutely astounded at the percentage of claims that are processed without an LCD, but let's just say it's the majority. I think we're on to the next thing I want to explain to folks, because obviously that begs the question, why do we need LCDs in the first place? Well, as a MAC, we have access to a large amount of claims data. We can see what our beneficiaries are accessing, what our providers are billing for, and that gives us a real bird's eye view into what things perhaps are being used most often. Many people assume that most of what we do is suss out fraud, waste, abuse, or vulnerabilities. And of course, that is certainly an important function. And it is something that we're always alert for. But in truth, most of our LCDs are completely blind to costs. And a lot of folks don't realize that. But when we write our coverage determinations, we don't bother necessarily about the price tags. However, you can easily extrapolate that if something is particularly high dollar in terms of amount, it might come to our attention, and or it might be a service that might be vulnerable to abuse. We want sometimes to make sure our patients have access to certain perhaps high dollar or other types of services. And this has relevance, for example, in a hospital setting where hospitals and big health systems want reassurance that something is going to be covered before perhaps they offer that patient a bone marrow transplant and the like. And then, of course, ever-changing medical landscape. Our evidence is always increasing, our technology is always increasing. We're always trying to do better, aren't we? So sometimes local coverage determinations need to emerge in part so we can guide those medical decision trees. Well, let's move on to the next. All right, so how do we even know if an LCD is needed? Well, a lot of that is dependent upon you. Our external sources, right? Because you all are still out there providing the good care. So our different stakeholders, folks who have a new technology may come to us. CMS may let us know that they believe that there's a need. Patient advocacy groups certainly have a hand in this. They may alert us to something specific. Specialty societies, in their wisdom and experience, may alert us to something that needs to get done. Other MACs can ask us if that's something that we need to consider also. And then, of course, internal sources. That data and claims review that I talked about can sometimes give us a different viewpoint from which to look at whether or not an LCD is needed. And let's talk about the next thing. And this leads me to probably, in my opinion, one of the most important things that I wish everyone understood, and that is, as a healthcare leader or a provider, how can you impact these very important coverage determinations? Well, I want to, again, pull back that curtain and let you know about several potential points of entry on that LCD process. And please know that we took a lot of your pre-submitted questions to pull this together so you all would get, again, kind of that bird's eye view that I wish I'd had before. And let's move on, because I'm really anxious to tell people about this particular bit. Yes, we got lots and lots of questions about what an LCD and how it functions versus a national coverage determination. Well, I think really the name tells us a lot. So national is a national policy that might grant, limit, or exclude Medicare coverage for a specific item or service. But a local coverage determination is just that. It's a regional proclamation where the MAC makes the determination. And yes, it's a little uncomfortable because it may vary between jurisdictions, but we'll talk a little bit about that. One of the potential positives about a local coverage determination is it tends to take a little less time to develop. A national coverage determination comes directly from CMS, and it trumps all of our LCDs. It applies to all jurisdictions, and as I mentioned, it can take years to develop. Both are based on the clinical evidence, but as you can see, only CMS can make changes to a national coverage determination, but MACs can make changes, and that makes us a little more agile. Let's talk about the next bit. So here's the number 5 out of the top 10 things I wish I had understood and wish our providers understood. So when we talk about reasonable and necessary for things specific to Medicare, it's not the same as FDA approved. There are very different standards. That is to say, the FDA standard, just because it's approved, does not necessarily make it reasonable and necessary. And let's talk about why that is on our next slide. So, the Social Security Act, in the hierarchy of all the things, all the regulations we follow, this is top dog. So in it is actually written that a MAC will determine if an item or service is reasonable and necessary. And then it defines those things for us. It says not only is it safe and effective, not experimental or investigational, but it's applied and appropriate, including duration and frequency. It's also very important to understand that it's furnished in accordance with general medical practice. It adheres to those standards, and it's specific to the diagnosis or treatment of the beneficiary's condition, and it's specific to improving the function of a malformed body member. It's furnished in the setting appropriate to the beneficiary's medical needs and condition, and it must be ordered by qualified personnel. And it must meet, but not necessarily exceed, the beneficiary's need. And you can see that that's a much fuller, richer definition than simply safe and effective. All right, let's move on to our next slide. All right, so how do we determine what's reasonable and necessary? Well, as is typical, we try to rely upon the evidence. And what does that mean? Well, for us, generally speaking, we try to determine what what the evidence directs us to do. And since the 21st Century Cures Act, which was enacted in 2016, it has changed a little bit how we do this. Now, for me, I've been here since this has been enacted. Nothing changed for me, but I understand that for some folks who have been around for a long time, this really encouraged us to change the way we thought about things. And it encouraged us to be very transparent about how we were using that evidence in order to determine what we were going to cover. And it looks like we've lost something. Oh, there we are. Okay. So yes, this really encouraged us to explain not only how we determined that this was evidence, but which evidence we used. We included bibliography, and then we explain our rationale, which supports our determination. All right, Mary, let's see if we can get to the next one. All right, well, here we are. I'm not going to belabor this point, but I wanted to just give you a glimpse into how we look at studies and how we grade them. That is to say, what weight we give them. We like very much if we can have at the top of that pyramid a systematic review, and those are best if they're done on randomized controlled trials, and a lot of them. Obviously, ones that are well designed with a lot of members and trials are best, but if those aren't available, certainly cohort studies might be the best that we have. Case-controlled studies are next down the line. And then, you know, honestly, as a provider, I often existed in the case series and case reports element. A lot of my patients in palliative care had very rare things. And then editorials and expert opinion is last. That's not to say that we don't look at guidelines, because we definitely do, but it is to say that we really put a bit of a microscope to all of those studies to see what weight they carry as we move forward with the evidence. And this can be, of course, very challenging. How do we weight those? Different viewers might grade this differently. Just for your edification, I do have at the end of my talk resources on the grade system of evidence. And that is something that all of the MACs try to adhere to. Next slide. All right, so if one does want to, you know, I think we're missing number 7. Mary, can you see if you can flip back? There we are. Yeah, I think we're a little glitchy here, but we're going to get through. So I really wanted to talk about this because this comes up over and over again, and I totally understand why. So why are LCDs different between the MACs? If we're using that evidence, if we're all grading as much the same way, how is it that we might use different language? Well, there is a balance, isn't there? So we want very much to adhere to evidence, but we might have regional needs that are different than another MACs. We might have regional needs that are different than our national needs. There's a tension there that we're always balancing, trying to make sure that we adhere to best standards while also meeting the needs of our beneficiaries. For example, one of our jurisdictions has a number of rural areas. We might need to be more sensitive to the needs of patients who maybe have access issues because of their distance from different medical centers. Now, one of my favorite things to do is a multi-MAC collaboration to develop an LCD. I really enjoy those, in part because there are some advantages, which I'll talk about. One is that many hands make light work, right? When we're all working together and we're all looking together for different evidence, sometimes we'll come upon something someone else hasn't. People think differently. We all have different specialties, and it's nice when you have somebody who has some expertise in it and the evidence that you're looking at. Now, disadvantages, there are some, of course. One is that our language can't necessarily be identical, even if it's necessarily very, very similar. And the other thing is it takes a bit longer, right? I think ultimately we can get a very good product and a better policy when we do it together, but it is a little clunky sometimes, and it's hard sometimes to share language between max for various and sundry reasons. The other thing I wanted to mention about LCDs and why they're different is because a really good local coverage determination is brief, but it's also dynamic, and that's where you come in. So it shouldn't be a static document. It should be something that grows, perhaps changes with evidence and with medical advances. And that's really why we depend on so many of you to let us know about those. The other thing that I wanted to make sure we talked about is that even though these are the best documents that we can conjure up at the moment, you know, Medicare and its wisdom is largely a study in unintended consequences. And when we write a policy, we may not know what those are until you let us know. And so it's really important that we have those lines of communication, and we'll talk about that. The other thing is something I want to bring up that's rather obvious, at least to those of us who work in the Medicare landscape for any length of time. And that is that Medicare is largely a good system, right? But it covers most of our beneficiaries most of the time. There's no way it can cover or allow for every single imaginable circumstance with all of the variation we have between beneficiaries and all of the variation we have between providers and even external access points. There isn't any way for us to design anything that's perfect, but the only way it works is if we're able to communicate back and forth. So let's talk about the very next top 10 that I want to make sure I reveal to you. And we had a lot of questions about this, and that's how to suggest a new LCD. Well, first and foremost, I want to make sure everyone understands that anyone can do it, really. It doesn't necessarily have to be from a provider. It can be from a stakeholder. It can be from patients and beneficiaries, really even other MACs. We, again, depend on these external groups to keep us informed and keep us as up to date as possible. So that leads me to my next slide. So here we go. Thank you, Mary. We seem to be jumping a little bit, but that's okay, we're good. When you have a new LCD request, here's something that I wish everyone knew. Here's an insider tip. When you submit something, please make sure it's complete, that explains the design, purpose, and method of using an item or service. It's submitted in writing, of course. It identifies the benefit category it falls under, and because that is not necessarily something I grew up knowing, I have a resource for you at the end of this presentation. The language is very important. What is it that you wish it to say? It is also important that there's some justification supported by peer-reviewed evidence. I love stories. I love case reports. It's really how physicians communicate, right? We communicate in stories by talking about cases, but a single case isn't really going to be helpful here. We need that peer-reviewed evidence. Set of guidelines also can be very helpful. We want very much for you to include the relevance, usefulness, and clinical outcomes or potential medical benefits of this new LCD. All right, let's see if we can get to the next slide. Another way for us to enter into this realm is to do a reconsideration request. Remember how I was talking about LCDs are dynamic documents? This is really what I was talking about. When we get a reconsideration request, it can come from anyone. It often comes from a beneficiary, a stakeholder, or a physician provider. And we want you to be successful with it. Obviously, it's going to occur in the MAC's jurisdiction, so we want to make sure you're on the WPS website. And one thing I wanted to talk to you a little bit about, which always makes me cringe as a provider, we will talk to you about a valid request. And that is to say your request has all the elements we need to consider it. We may deem your request invalid. That's not to say it's not worthy of consideration. It merely means that there are pieces missing that you might need to fill in and get back to us later. All right, next slide. Here we go. So reconsiderations, it's very important to know, and I think this is kind of tricky, but let's say that we have a draft LCD going forward. One of the things that you can't do at that point is ask for a reconsideration because it's not a final effective LCD. So we need to make sure that that process is complete. So you may have to wait until the finalized version comes to pass. And either the entire LCD or any part of it could be subject to reconsideration. So if there's a sticking point for you, by all means, address it if there's that pain point. And the other way to think about this is that when you're thinking about the totality of a local coverage determination, sometimes things change, and we get that. There are elements of things that we can't even imagine when we're writing an LCD. Let us know what those are. It is really important. Nothing is too small. Recently, we changed something that allowed our patients with enlarged prostates not to have to worry about getting a transrectal ultrasound in order to get the subsequent procedure. Well, okay, it's a very small thing, but we changed it, and it probably affected a good many men in our beneficiary categories, and they're probably very grateful that we changed it. So when we get a request, Max will review it from oh, here we go. Mary Sue's just testing me. We'll review requests from beneficiaries, providers, and any party interested in doing business in the jurisdiction. So sometimes we have outside parties that say maybe from a different state or area, but it's okay because what they're what they have is actually going to be utilized in our jurisdiction. I think that's important. All right, let's go ahead to the next slide, Mary. All right, I think we're missing one in between. There we go. Okay, again, like the brand new LCD request, a valid reconsideration must include the specific language to be added or deleted, any edits you want, the benefit category, and including the rationale justifying the assignment to the benefit category. As Karen mentioned in the first talk, sometimes that gets a little bit challenging. Also, any justification for the change supported by the evidence in the literature, and that level of evidence review is the same as it would be for a new LCD. All right, let's move on to the next bit. Okay, so here are the things I wish that my providers knew when they went for a reconsideration request. I wish they knew that we can't open any links in the emails. When I was a provider, email links were just fine. In fact, they were great because they didn't clog up my memory. But in this environment, we actually need the full published, full text article, not just the abstracts, and they need to be published in English. We simply can't open those links because of security restrictions. And it breaks my heart when someone's obviously taken time to get the evidence all together, but it isn't in full text form. That would be, as I mentioned, an invalid request. And that happens actually probably more often than it doesn't. And then obviously, any information that addresses the relevance, usefulness, clinical health outcomes, or the medical benefits of that particular item or service, really helpful. Remember, we might not be in your specialty. So in any way that you can make it relevant for those of us who perhaps don't know the lingo is really, really useful. All right, let's see if we can get to the next one. All right. You know what? I was hoping, Mary, if we can go back to lucky slide number 13, because I think we skipped that one and it's one of my favorites. And since we have a little bit of time, since we went through the abridged version, let's see, one more. There we go. Yeah, it just doesn't want to stay there. This was really important for me to share with you because it's something I had to learn. It's not intuitive at all. Several of you wanted to know the life cycle of an LCD, or how you can penetrate this cycle, how you can be a part of it, how can you impact it if you see something that you think either needs a consideration or a coverage determination or reconsideration. First of all, identify that pain point, that need for an LCD. Get that LCD request or reconsideration together and approach us. When the MACs are considering this, one of the things that we do is we may consult with our Contractor Advisory Committee or CAC group. Those are our ready-made group of advisors who help us if we have a lack of understanding and need to understand a little bit more, say, for example, of an ophthalmology LCD that we think we're going to alter. We might actually at some point go even beyond our Contractor Advisory Committee and host an evidentiary CAC meeting. This is a very specific type of meeting that is there precisely to garner more evidence and potentially to have people of opposing viewpoints talk about their level of evidence and why they believe their particular approach is the best. After that meeting, and in concert with perhaps other subject matter experts, and importantly, our internal experts, we have policy coordinators who are expert at language. We also have research analysts that help us. This might also be the point at which we, if we're doing a multi-MAC LCD, begin our conversations and start the process of drafting and thinking about the language we're going to use. We will then post that draft, and during that period have an open comment period. We really do try to make it easy when we have a draft LCD for you to have comments and post those. And we encourage you to do those in writing with as much detail and evidence as possible. During that open comment period, we will also have an open meeting, and it's just as it sounds. It is sometimes coincident with a Contractor Advisory Committee or CAC meeting, but it is separate in that it's also open to the public, as Karen mentioned. After that time period, we'll close the comment period. We'll look at those comments. We'll try to integrate as much as we can. We'll look at things critically, expand our evidence if that's appropriate, and then we'll develop that final draft and post it. And then we give CMS a 45-day notice that says, hey, this is what we came up with. This is what we're posting. And then it becomes final. All right. And let me just take a look and see if there were any other important slides that maybe we missed. I think we're good. Let's go ahead and jump to slide 27. I know that you all are out there doing good work, and I know from firsthand experience that it can be really challenging to make your patient fit exactly in that local coverage determination or that national coverage determination. These things are written not to frustrate you. They are written because we want our beneficiaries to get the best care possible. And believe it or not, we actually want our providers to have the best experience possible. We want to make this seamless if it is as much as possible. And again, we like to write good LCDs. We want to make sure that they do what we want them to do. You can help us in that when you submit to us either a reconsideration request or a request for a new LCD, that the design, purpose, method, and item or service for which you are making the request is appropriate. And I've included our very own WPS LCD and NCD reconsideration process link because I really, really want this to work for all of you. I think, you know, Medicare is a tough landscape sometimes to work with, and I understand that. But there are opportunities for us to work together. And I think it works best when we have partnerships, both those of you who do the actual work and those of us who are trying to draft good policies. And then I think my very last slide just emphasized that you really do matter to the LCD process. I really don't think I knew that before this. I kind of thought of it as sort of this black box and these LCDs just kind of came out. But I see the dedication of the folks who are trying to write these. I see how smart, and some of them are frankly brilliant, and how much it matters to them that these things work. So if you can reach sort of across that aisle and help us do better, we definitely want you to be a partner in that process. And then I'm going to open it up for questions. Here are some resources. Again, I wasn't born knowing any of this stuff, and I really appreciate when somebody gives me a nice list of resources that are actually meaningful. So these are the things that I use often. They're on my list of frequently accessed sites, and they keep me on the straight and narrow and keep me working hard. And there we go.
All right. Thank you, Dr. Vlahakis, and thanks to everyone, especially Dr. Vlahakis, for putting up with the gremlin that exists in my computer today. I think I've figured out it's the gremlin is residing in my mouse, and if I use my arrows, I don't have the issue. But again, thank you for being patient with that. So I think we have everything covered. I do want to go over some questions in the chat and some other pre-submitted questions while we still have a few minutes. So there's a question that just came into the chat from Tracy, and it says, draft LCDs should be finalized within 365 days or it will be retired. What will MACs do to notify the public what is going on with a draft LCD if it was not retired at 365 days? For example, an extension beyond that 365 days.
So I actually had the good fortune of working on one of these LCDs that we worked on for a long time. It was pretty much ready to go at a year, and we had to press pause, largely because of the new administration getting caught up to speed and our new CMS director. So we've begged patience with our folks who are waiting with bated breath for those LCDs. I will tell you, we are just as flummoxed, but trying to maintain patience with this. And yes, when we passed that 365-day mark, we were given, without any ceremony, extensions on that. So I suspect that a good many of our LCDs are going to be lying in wait. Hopefully we can get some of them through in the fall, but it may be that mile marker, January of 2026, that we find a lot of our LCDs going through. And again, I suspect that's largely due to our new administration getting caught up to speed and wanting to make sure that we promote the best policies possible. And actually, Karen or Mary Sue, I might need you to demonstrate where we might find that on our web pages.
Sure.
And I have to say, this group in attendance, you have had the best questions, and I can't thank you enough for the pre-submitted questions. I was so excited when I saw them because they were kind of the same things I had questions about when I first started and wish I had somebody to tell me.
All right, if you want to guide me from here to what part you wanted me to show the providers right now, I have the policy, and I'll kind of back up for those who missed it. I this is our homepage when you enter our website at WPSGHA.com. I went into Topic Center and then I chose policies. So this is the splash page, if you will, for better words, guides and resources, all things policy start here. And then from here, I'll have you tell me, Dr. Vlahakis, what else you wanted me to show providers today.
Well, the policy that I personally worked on that needed the extension after 360 days is the botulinum toxin LCD.
Perfect. So what I'm going to do, just because this is how I get to our local coverage determinations, is I'm going to go to CMS's website, because all LCDs are housed on CMS's website. We may provide links to you, but the actual LCDs are housed on CMS's website. So if I go to just cms.gov and I go to Medicare and I go to coverage and I go to the Medicare coverage database, this is where I will find all local coverage determinations for all Medicare contractors. Dr. Vlahakis, do you by any chance have that LCD number available? If not, we can search a different way.
No, I don't. I'm so sorry. I should have it memorized by now. But I know that there's the only one of them for the botulinum toxin for us. Looks like, here we go.
I'm just going to actually search a different way, and I will show you. I will just put in the keyword of botulinum tox or botulinum, and I am going to choose a WPS known state, which is the state of Iowa. And so then I will have it drilled down to the botulinum toxin LCDs for us, WPS, as a contractor. So would you like me to open this draft or the type A, type B?
The proposed LCD is the one that's in limbo at the moment.
All right. So when I go to that draft, the DL, so we have a little bit of information on the issue description that comes up, and it tells you who our contract medical director is on this, and it's the great Joelle Vlahakis down here. I'm going to close this, and here is that proposed LCD for you. Dr. Vlahakis, did we lose you?
Oh, no, I'm here. I'm trying to, I've never looked, to see if they put an announcement that we are in an extension.
With that, I'm going to scroll to the bottom. So avert your eyes if you have any kind of seizure disorders while I scroll quickly. And I was just trying to see if I could see any information in the bottom here on the draft information. Again, lots of resources, scrolling as quickly as possible. Okay. And bibliography information, and it doesn't look like, unless I went through it quickly, if there was explanation.
Now, I think the only way you would know is if you happen to glance at our open comment meeting date and see that it was 2024. And know that that must be an extension. You can tell if something is no longer active because it will mention it at the end. that it was superseded or no longer active. But if it's active and it's beyond its date, that would really be, in my opinion, the only way to know. And you would have to look up the specific LCD.
And here are some links at the bottom to the MAC meeting information URLs as well. So if we find some additional information, we will put that out in any with any questions for the day that were not fully answered, to give a little bit more explanation to our provider base, you know, to help you find that information as well. So in the interest of time,
don't be shy about letting us know which specific LCD you might be referring to, because that will help us out a little bit in answering your question.
Yes, absolutely. So I am going to jump back to the presentation portion, and seeing no other questions in the chat right now, I'm going to go ahead and move on in the interest of time to keep everyone moving, because I know many of you are registered for different events today. So in a few minutes, you guys are going to receive a certificate of achievement, an email. And that email is actually your certificate if you need that for contact hours for possible CEUs. So don't delete that email without taking a look at it and reading it. It also is going to provide you another link to our survey so you can provide feedback on today's event. If you have follow-up questions that were not answered today, I do encourage you to go ahead and send those to our email address. And again, that email address is wps.gha.education@wpsic.com. Go ahead and put something in the subject line about top 10 LCD questions, or demystifying LCDs, or something that we can identify that this was specific to this event for today. We do ask you to, please complete your survey, because that's our way of knowing not only how you felt about the event, if you liked today's event, but it's also your opportunity to give us what you need in the future. We plan on doing other events like this in the future, where we choose a whole day and we focus on a specific topic that is of interest to a large majority of our providers. And so we do ask you, take the time, let us know what else you want in the future, or if there's specific local coverage determination information that you want us to do in the form of an educational event. That's your opportunity to do that as well. All right, I just want to let you know that we hear you. Based on those feedback surveys that we have gotten, we have made some improvements to your educational experience. Things like this event. This was a suggestion by many different providers that they wanted an event such as something like this to cover a large variety of topics on local coverage determinations. We've also made changes to our YouTubes where we actually have embedded chapters in those. So now if you're listening to the encore of an event and you just want to go back through a specific portion, you're going to be able to click on those chapters and take you to that specific portion to re-review. We've added training indicators to our events to tell you what that event is pertinent to, or who that event is pertinent to. Is it clinical? Is it billing? Is it specific to UB04 or 1500 billing? Is it something that is policy related? So look for those training indicators, and you can find explanation of those training indicators on our website as well. So on behalf of Dr. Vlahakis, myself, and all of Provider Outreach and Education, we want to thank you for attending today's event. We look forward to your participation in additional events that are happening today, as well as future events that we are hosting. So thank you again for your participation today, and you can now disconnect.